procedure skill or station and its question STEAM, you will be given 3 stations. Number 1, strangulated inguinal hernia. That was the difference. In the PDF file, it was written only inguinal hernia. If it is only inguinal hernia, definitely it will not come as a first case. But if it is
Not urgent.
strangulated,
It's not
yes,
urgent case.
yes.
It's urgent.
Diabetic, yes. Diverticular abscess planning for sigmoidectomy and has pacemaker. Okay, this is another importance. And pacemaker patient always with some what?
And then this is major surgery.
Yes. And below-knee amputation, insulin-dependent diabetes mellitus, MRSA, and on warfarin for atrial fibrillation, allergic to penicillin and iodine. How are you? Are you okay with the OT list? No. So first operation, what you want to keep? Strangulated inguinal hernia to save his bowel. Second operation, diverticular abscess
Diverticular abscess.
with pacemaker.
And
And third case,
the third,
below-knee
BKA with
amputation,
MRSA.
MRSA. Now, question starting from first case. COPD with inguinal hernia with bowel obstruction. This is the first case. Why this patient of COPD with strangulated hernia should go first? Answer is
Saving his
saving his
bowel
bowel.
because strangulated hernia can cause bowel ischemia.
Yes.
Also, COPD patient need longer time in recovery room and may require ventilatory support
So mainly two
post-operative.
things. Why? First is to save his
It's
bowel
a urgent
because
case. Yeah.
this strangulated hernia bowel may proceed to ischemia. And second, this is a COPD patient, so patient might need prolonged recovery time and also may need ventilatory support. What type of anesthesia you will give?
Spinal anesthesia.
Spinal anesthesia. Okay. Why you will use spinal anesthesia?
Because COPD may have high risk of hemodynamic instability and laryngospasm and risk of post-operative complication. COPD also may have delay recovery at recovery room, so may need ventilator support.
So you are not
So
giving general anesthesia. You are giving spinal anesthesia. Why spinal anesthesia? Because COPD patient have risk of hemodynamic instability, laryngospasm, and risk of postoperative complication. Also, COPD patient may have delayed recovery at recovery room and he may need ventilatory support. That's why we will give the patient spinal anesthesia.
anesthesia.
And where to manage the patient?
In ITU.
ITU. Okay. Then you will be asked about the second stem. Diverticular abscess planned for sigmoidectomy with pacemaker. What type of anesthesia you will give?
General
General.
anesthesia.
Why general?
Because it's laparotomy.
No, not laparotomy. Because of laparotomy. It is because of patient has pacemaker and pacemaker patient always will
Oh
have
yeah, will be on warfarin.
anticoagulation. Anticoagulation. And anticoagulation patient have the chance of spinal cord, spinal hematoma.
Hematoma.
Spinal hematoma. The patient with pacemaker will be on warfarin, so may have coagulopathy, and it is contraindicated for spinal anesthesia. Okay.
But no one do sigmoidectomy under spinal. And then people do the sigmoidectomy under spinal, high
And
spinal, is it?
can do, yes, high spinal, yes, and under sedation. Some sedation also will be there. Spinal also with sedation. So what to do pre-op to optimize this patient? Because patient is pacemaker. So arrangement of temporary pacing in the operating table with cardiopulmonary resuscitation. Two things. One is arrangement of cardiopulmonary
temporary pacing
pacing in the operating table, and cardiopulmonary resuscitation
resuscitation table should be available.
in the OT. Intraoperative, what to do? Use only bipolar.
So bipolar,
If bipolar not available, use short burst
short burst
monopolar.
monopolar.
Use short burst monopolar. Where should be the end plate placed if doing surgery in the left inguinal hernia? If left inguinal hernia, so under the left thigh.
Left side, yeah,
Same,
should
same
be
thing.
nearest possible.
What will you do after sigmoid colectomy?
We create an colostomy
Sigmoid
and
colectomy, we
colos.
create end colostomy. Sigmoid colectomy, sigmoid colon remove. This is ascending, transverse, descending sigmoid. Sigmoid colectomy. From here, we remove the sigmoid. So what we'll do, maybe this part, we will make end colostomy, right?
And
We will
colostomy.
make end colostomy. And we'll make here a rectal stem. Okay, end colostomy. Who to involve? Colostomy specialist,
Colostomy specialist and
colostomy
colostomy nurse.
nurse. Then you will be asked about the third patient. So third patient was diabetic and planned for below knee amputation. Patient on warfarin for atrial fibrillation and allergic to penicillin and iodine, and also positive for MRSA. Why? This is a diabetic patient, but why you put it in the last?
Because patient have MRSA to prevent cross contamination between patient.
Yes.
Diabetic patient we can actually keep nail by mouth later.
Yeah, no need to keep nil by not more than 2 miss meal.
So allow orally until 8 or 9
Yes,
a.m. in the morning.
yes, yes. We usually do like that. What will you do after this case? Fumigation of the theater.
Fumigation of the theater.
Hmm. Fumigation of the theater. What to give in penicillin allergy?
Erythromycin or
Erythromycin or
vancomycin,
vancomycin?
lastly.
Cefazolin.
Mhm.
Erythromycin or vancomycin or cefazolin. Erythromycin or vancomycin or cefazolin. What is the importance of iodine allergy? It
I will
is,
not use
I will not
patient
use.
iodine allergy. I will not use to prepare the solution. And to prepare the skin. I will not use preparing solution of povidone iodine.
Yes, I will not
So
use
we
povidone
use
iodine,
something else.
chlorohexidine.
Mm. Alcohol.
Yes, chlorohexidine, even if it is out of stock, we can
Aqueous
use
okay.
any alcohol-based solution.
Solution.
Alcohol-based solution. What precautions to be taken? If we use alcohol-based solution, it should be dry
We
completely.
must wait. Yeah, we must wait until the solution evaporate completely.
We must wait until evaporates completely and then start surgery. What to do to ensure glucose level to optimize intraoperative?
Measure glucose level hourly during the operation.
Measure glucose level hourly during the operation. Measure glucose level hourly during the operation. What is the difference between the bipolar and monopolar?
In the monopolar, the current pass from the active electrode through the tissue operated and back into the plate to the patient. So the current flow from in the large surface area. So in the
Only this.
bipolar, the current
Mhm.
in bipolar, the current pass between two tip of active electrode. Therefore, only passing tissue lies between these two tips. But then in the monopolar, is from the outside active electrode to the tissue being operated and then back to the electrode plate of the patient. The current
Monopolar.
disseminated
Mhm.
larger
Mo-
surface area.
Monopolar means one pole, just positive. So, there must be another negative pole, and that negative pole we put it in contact with the body surface, where body surface area is muscular and larger than 70 centimeter square, also hairless. And thing is, in between two electrodes, this is one end, and if this is another end, in between patient body will be there, like that. Suppose here we are working with monopolar, we have to keep another plate, and this body remains in contact with the plate. So electricity passes in between this body. That is the current passes from active electrode through the tissue being operated to an electrode plate on the patient. So patient body involved in the circuit. They want to hear this
Body involved.
sentence. Patient body
Body involved
involved in the circuit.
in the okay.
And in bipolar diathermy, the current passes between the two tip of the electrode, and current passes in between only the tissue being held in between the tips. Therefore, only passing through the tissue that lies between the tips. There is no electrode plate. If the first patient who has strangulated hernia, also atrial fibrillation and warfarin, and going for emergency surgery, what preoperative management you will take? So patient also have warfarin and emergency surgery.
So we should urgently consult cardiologist consultant for AF. Measure the coagulation status. INR is more than 3. Should give antidote like warfarin or prothrombin complex concentrate.
Yes.
And then reverse the warfarin. Aim INR less than 1.5 before operate.
Okay. So the same question, if patient have atrial fibrillation, then what we'll do? But surgery also urgent. So we'll give urgent cardiologist referral, and also we'll measure the INR, INR, and if it is more than 3, then we will give prothrombin complex concentrate, right? Also, we can give vitamin K. I will give the patient
IV.
IV, yes, prothrombin complex concentrate, and I will give patient antidote for warfarin, prothrombin complex concentrate, and vitamin K. And target INR, it should be less than 1.5.
Yeah.
How would you manage this patient's anticoagulation? Now it will come. We'll check the local policy and ask advice from the hematologist. If it is low thromboembolic risk, stop warfarin 5 days pre-op and restart warfarin post-op as soon as the oral food tolerated. And high thromboembolic risk, stop warfarin 4 days pre-op and start low molecular weight heparin at the therapeutic dose, that is 1 milligram per kg per day, and stop low molecular weight heparin 12 to 18 hours pre-operatively and restart low molecular weight heparin after 6 hours. Once we get we make sure that adequate hemostasis have been achieved, then we will we restart warfarin when oral fluids are tolerated, and then we do breathing, and we check the INR. If it is within the normal range, which is 2 to 2.5, then we can stop low molecular weight heparin and can continue warfarin.
Warfarin.
The end of the station. See the next note for extra questions. Okay. Examiner asked about arrangement of OR, about pre, intra, and post-operative operation for every case. Only one question in Cairo. See answer below. How would you try to reduce the risk of patient with COPD about to undergo on operation? Okay, pre-operative measure, what we can do? Optimize his
Optimize
medication,
medication,
treat
treat
any
any
infection,
infection, stop smoking.
smoking. Yes, it is respiratory physiotherapy. Intraoperatively, use open surgery, not laparoscopy. Use regional anesthesia instead of general anesthesia. Post-operative, chest physiotherapy before and after surgery. I would inform HDU
Adequate.
in HDU in case more intensive care is required post-operatively. Complications of the
And then
patient.
can add like adequate pain management and chest physio as well post-operatively.
Complication of the patient may get pneumonia, ARDS, basal atelectasis.
Vessel metastasis.
What investigation you will arrange before the operation? Chest X-ray to rule
Chest
out
X-ray,
uh,
spirometry and lung function test, baseline blood gas.
yes, you can do chest X-ray, spirometry and respiratory function test in ABG. What chest X-ray, spirometry and ABG. What category of strangulated hernia? It will go under
It's
urgent.
urgent. Urgent.
What precautions would you take in patient with pacemaker in elective case like this?
Arrange a pre and post operative pacemaker check. Contact their pacemaker follow-up clinic to inform the operation and ask for advice. In OT, we ask nurse to prepare arrangement of temporary pacing in operation table, prepare cardiopulmonary resuscitation equipment. During operation, use bipolar instead of monopolar, and if monopolar is needed, limit to short bursts only. And the return electrode should be placed so that the pathway between diathermy electrode and return electrode is far away from pacemaker and lead as possible. Okay, what you need from nurse to prepare inside OR?
Cardiopulmonary resuscitation and temporary pacing equipment on the OT table. In this model, where should you put monopolar? Put under the right thigh.
Right, right. Operation on the right side. Yeah.
Yes. Criteria of
Criteria of monopolar.
monopolar. Hmm. The surface
Surface
area
area 70 centimeters square,
70
dry,
centimeter square.
square,
It should be
dry,
dry,
hairless,
hairless, and muscular.
muscular.
And precautions for diabetic patient going for surgery. How to prevent intraoperative hypoglycemia? Okay, before operation, routine overnight admission is not necessary. Starvation time should not be more than 1 meal. Order ABC and potassium level, very important. He said this is very, very important. This one we
Yeah.
must not miss. Also HbA1c.
Mm-hmm.
Order ABG, potassium level, blood glucose level, and HbA1c. During and after, patient with diabetes must be prioritized in the OT
In the
list.
operative list,
If diabetes is controlled by oral medication, just omitting the morning dose and use short acting very okay. And if diabetes is not controlled by oral medication and if patient is expected to miss more than 1 meal, then if these two conditions will follow this. What? Short acting variable insulin infusion. This is important. I always forget this one. Analgesia and
analgesia
antiemetic should be
and
used
antiemetic should be used
to enable the
to
early return to
enable
diet.
return to diet. Uh,
Then
half
remaining
saline,
fluid they
0.
said half normal saline, point four.
0.545 saline
Mm-hmm.
is half saline
Hmm.
with 5% glucose and 0.15% or 0.3% potassium chloride is recommended IV fluid. And then capillary blood glucose should be measured hourly during and after in ward, monitor every 4 hours. The target blood glucose should be 6 to 10 millimole per liter. So the fluid is half saline plus 5% glucose plus potassium chloride, or either 50%, 0.15% or 0.3% should be given to the patient. And capillary glucose monitoring hourly during intra-op and 4 hourly in what?
Post-op. And target sugar level?
Target should be around 6 to 10 millimole per liter.
What type of insulin will you use? Short acting.
Short acting.
How to
How
give
to give
insulin?
insulin by variable insulin infusion, VVRI, variable virtual
Variable insulin infusion or sliding scale. Variable insulin infusion or
VRI,
sliding.
VRI. When to stop oral hypoglycemic drug? All oral hypoglycemic drug can be stopped just at morning by omitting morning dose, except sulfonylurea, and metformin should stop 1 to 2 days as it causes lactic acidosis. Fluid to give post-operatively?
0.45% sodium chloride with 5% glucose and 0.15, or if you make it double, it will be 0.30 or 0.3 of KCl, potassium chloride. Alas, oh, word listing finished.
Alas.
Can we take a small break? Not a small, 30 minutes maybe. You can pray, then we can
Yeah,
finish.
I need to pray.
You can pray, my prayer time also will come. So, remaining are easy, like excision of nebus. This thing are easy. Then abscess drain. These are small.
Okay.
Okay, doctor.
See you in 30 minutes.
Yes.
Okay, bye.